Hello, everyone. We are going to be joining our series 3 of the team model. And if you haven't missed some of our last recordings, please go on and you can find them online through the webinar link. And today we'll be covering anchor hospitals and collaborators and requirements. We are Rainfall Health, and we use AI-enabled technology working specifically with health systems to maximize care reimbursement. And if you want to find out financial impact analysis for your facilities, please reach out to our team directly, and we'll be happy to assist you. Today, we'll be covering the collaborators and requirements, and they'll be taken on by Marla, who's our VP of Operations and our resident expert on the team model. Marla, if you want to jump in, provide a little bit about your background, and then we can jump into the topics of discussion today.
Sure, sounds great. Again, thank you all so much for joining today. As I'm shared, today is the third part of a multi-part series to share information about TEAM. So during our first session, we discussed the how, what, when, why of TEAM. Our second session, we took a deeper dive into the MSDRG and HCPCS codes, the new CQS measure, and the quality measure. So if you did miss those two sessions, please reach out and we can connect you to those webinars. So during our second session, we briefly touched on the definition and responsibilities of anchor hospitals and collaborators. This is the focus of today's webinar. We'll also briefly revisit episode duration and cost and explore the sharing arrangement requirements between anchor hospitals and their collaborators. All right, with TEAM, as we've talked about in our previous series, when a procedure or admission for one of the 5 TEAM designated procedures starts at a TEAM mandated facility, that 30-day clock starts. That TEAM facility, which is the anchor hospital, is responsible for coordinating the patient's care for the next 30 days. Again, as we've mentioned before, that means scheduling with a primary, occupational therapy, durable medical equipment. That's on the anchor hospital to coordinate the care and is responsible for cost. So let's talk about episode target cost one more time. This includes the procedure and wraparound services for that 30-day episode duration. Sometime in November, projected, CMS will share the episode target cost with TEAM participants. Episode target cost, again, is a facility's North Star to maximize reimbursement. So briefly, again, we talked about this last time, but it is important to understand the factors that are used to calculate a participant's target cost. Those include regional data, participant quality measure data, participant claim data, that's a 3-year baseline period. That 3-year baseline period is going to be weighted. So we can see here in baseline year 3 being weighted at 50%. That is the most current year, anticipating that the most recent year to be the most accurate predictor of performance year spending, right? So therefore would contribute most strongly to the benchmark. And then we can see year 2, year 1, how it decreases in that weighted measure. So these target prices are based on Medicare Parts A and B items and the services included in the episodes. They will be risk adjusted based on beneficiary level and hospital level factors. All right, so we know that to be true in the final rule. However, in the new proposed rule that came out April 11th, a couple weeks ago, there are proposed changes to calculating the episode target cost. Again, while it's not up to you or your facility to calculate your own target cost, it's important to know and to understand what factors contribute to those target costs and what are being proposed. So here's a few things that are being proposed. Episode target price based whether or not your facility has sufficient quality data. So we know that quality data is significant in calculating the reimbursement score. So if your facility, this is proposed, is determined to not have sufficient quality data, it is proposed that your facility will be assigned a neutral quality score. which will neither positively or negatively impact your facility, right? But so it's important to understand that. Do you qualify for that if it goes to final rule? Another thing that's being proposed is replacing the area deprivation index with the community deprivation index, which better reflects the socioeconomic conditions of the communities that will be served through TEAM. In the final rule, there was mention of a look back period, but it wasn't finalized. What is being proposed from the April proposal is using a 180-day look back and HCC version 28 for those beneficiary risk adjustment, right? So HCC varies depending on the procedure. Also important to know that there are 26 of those codes that are specific to TEAM that will be subject to that 180-day look back proposed, right? Those are high level. There's a few other really more technical methodologies that are being proposed. Yep, feel free to take a look at that proposal or reach out to us and we'd love to help you. Okay, so we've reviewed factors that contribute to target episode costs. I want to switch gears and I want to talk about anchor hospitals. As we know, the anchor hospital is responsible for coordinating care with other providers and managing the patient's care during the 30-day episode. Episode begins from initial hospitalization or the procedure, so we can think of the anchor hospital as the central point of care for the episode duration. I do want to go through a few examples. These examples are taken straight from the final rule, but it helps to illustrate the nuances of anchor, what constitutes when the episode actually starts, and what could be involved in that. So let's run through these 3 examples. Okay. A beneficiary is admitted to Hospital A. Hospital A is a TEAM participant. They're admitted January 1st with MSDRG code 637. That is not a TEAM episode qualifying procedure. They're discharged January 5th with a transfer to Hospital B on the same day. Okay, so the beneficiary is admitted to Hospital B for a qualifying TEAM procedure, MSDRG 470. Then they're discharged January 10th. So 2 hospitals, 10 days, one that was admitted to a different hospital from a TEAM participant hospital. Okay, so in this example, the episode is attributed to Hospital A and is considered an LEJR episode. So it's that MSDRG 470 episode with an anchor hospitalization start date of January 1st and an anchor hospitalization end date of January 10th. So all the spending between both hospitalizations would be captured in that episode, right? So we can see it's a little bit more nuanced than just start end date. Really important stuff to know. Let's look at another example. So let's use the same thing, but let's say Hospital A is not a TEAM participant hospital. Hospital B is a TEAM participant hospital. In that scenario, neither hospital would be attributed to the episode since Hospital A is not a participant and the transfer policy prevents the episode from being attributed to Hospital B, right? All right, let's look at one final episode when we have services involved. So there may be some instances, obviously, where a service included in the episode begins during the episode, but concludes after the end of the episode, and for which Medicare makes a single payment under an existing payment system. So example, we have a beneficiary in an episode who is admitted to a skilled nursing facility for 15 days. Beginning on day 26, so in that 30-day window, beginning on day 26 from a TEAM anchor hospitalization or anchor procedure. The first 5 days of the SNF admission would fall within the episode. The remaining 10 days would not be included in that episode, right? So timing matters, procedures matter, community partners, your collaborators matter. Really important to understand the nuances of what an anchor hospital is responsible for when it comes to those timelines. Okay, so let's take a look at what could be included in the list of services that would contribute to episode cost. We looked at some of these, I believe, last series, but just to give an example of what are services that would be considered underneath an episode spend. So we can see here, obviously, skilled nursing facility, outpatient therapy, clinical labs. There's, quite a few things that can be covered. Very important to understand what is could be considered in that episode cost. Okay, one thing I do want to point out here with physician services, in the final rule, primary care referrals is a requirement. So patients transitioning, they have to have a primary care referral. But in the April proposed rule, CMS is seeking comments regarding this requirement. So we may see some changes there in an upcoming final rule before TEAM goes into effect in January. One other thing they changed or proposed in the April is to expand the 3-day skilled nursing facility rule waiver, giving patients a wider choice of access to post-acute care. So that's something to keep an eye on as well. All right, so we know we're learning what we know about what contributes to episode cost and the responsibilities of anchor hospitals and the services that can be involved. It is really important to know that hospitals will be monitored to ensure an anchor hospital is not withholding care, meaning care is not withheld in that 30-day episode period to give the appearance of lower spend. So what's going to be monitored or evaluated is determining if that anchor hospital has a higher than their regional average care of cost post 30 days. So remember, that's one of the things for a target cost is what's happening in your region. That will also be monitored, again, to make sure an anchor hospital does not have higher post 30-day spend than their regional average. If they do, they could be penalized well beyond the stop loss max for the track that you're on. We'll talk about tracks next time. Okay. So the providers of the services that we just talked about can be considered collaborators of the team participant. To be considered a collaborator, there are requirements and sharing agreements, sharing arrangements. So we're going to talk about those, but first, it's important to understand this does not mean beneficiaries that qualify under TEAM are only referred to collaborators. The patient still has the right to choose. As a matter of fact, there are specifics outlined in the final rule pertaining to patients' right to choose and be informed about TEAM. The final rule requires that appropriate beneficiary notification should be given to the beneficiary or their representative by the anchor hospital and their collaborators, and should do the following. The beneficiary notifications need to explain the model and how it will or will not impact that beneficiary's care. It needs to inform the patient they still have the freedom to choose providers and services. And of course, explaining to patients how they can access their care records, claims data, that their claims data may be shared with team participants, and that the patient still has access to their standard Medicare beneficiary protection, 1-800-MEDICARE, to report any concerns of quality of care. Here's the thing too, providers or participant hospitals have to provide a list of all their sharing arrangements in the TEAM model. Right, so it is recognized that this could be a pretty exhaustive list of providers, suppliers, services, and it could make the beneficiary notification really unnecessarily long. So it will be acceptable to meet this requirement by including in the beneficiary notification a web address where beneficiaries can access the full list of a team participants' collaborators. Right? Team participants also must require all of their collaborators to share beneficiary notification materials as well, right? So these have to be written notices, applicable obviously to the team beneficiary, and it's got to share more about the sharing arrangement, disclosing that the basic quality and payment incentives under the model between the two entities. These notices must be provided by the collaborator no later than when the beneficiary first receives an item or service from the team collaborator during an episode, right? So it's got to be day one. If for some reason the patient's condition does not, it's not practical to give that notification, the notification must be given as quickly as reasonable or to their representative as soon as it is reasonable to do so. Right, so that's something to keep an eye on there. My understanding is too that there will be involvement from CMS. They have to approve those notifications and may possibly offer assistance. Not real clear on that, but that is something that they will want to see and be involved in. Okay, so let's switch gears. Let's talk about now the requirement between the participant, the anchor hospital, and their collaborators. Understanding that the purpose of collaborators and the expectation of collaborators is to work alongside participants for activities related to promoting accountability for the quality, cost, and overall care for team beneficiaries and performance in the model, right? So collaborators are held to the same high quality standards of the participants with whom they have the sharing arrangements. So let's talk about that a little bit more. That means that collaborators, they have to comply with applicable provisions for the final rule, which includes the beneficiary notifications that we just talked about, participation in any evaluation, monitoring, compliance, and enforcement performed by CMS. Right? And the reason is because these collaborators will all play a role in the model care redesign. And they're being financially incentivized to participate in this model. So super important who anchor hospitals participants choose for their collaborators. There are some things that are required in the sharing arrangements between the two. Let's run through a few of these briefly. So the financial arrangements, again, between participants and collaborators, they're called sharing arrangements. In those sharing arrangements, there are specifications for payment. So there can be a payment between a team participant and a team collaborator. That's called a garnishing payment. There can also be payment from the collaborator back to the team participant. That is an alignment payment. So when the agreement is created between the two organizations, there are some things that do need to be included, as with any standard agreement. Obviously, the purpose and scope of the sharing arrangement, who's going to be involved, the parties involved, and what services they're going to perform underneath this arrangement, the date, and what management staffing will be involved in executing the scope of work. There also needs to be details around the financial or economic terms for payment that we talked about, that garnishing payment or that alignment payment, as far as, what constitutes that, what's the eligibility criteria, what's the frequency, what methodology and accounting formula will be used to calculate those payments. All of that needs to be in the sharing arrangement. So in addition to the services that can be part of an episode, there are providers and suppliers that are Medicare enrolled and eligible to participate in Medicare, or entities that are participating in a Medicare ACO that may be considered team collaborators. So we shared potential partners or services on a couple of slides ago, a couple of previous slides, but just want to call out other entities that could be considered. Could be a therapist in a private practice. It could be Medicare ACO, non-physician provider group practice. So there's quite a few that we could pull from to be collaborators if we are that anchor hospital. In addition to the written sharing arrangements between the two entities, team participants internally should have written policies for how they're going to select their team collaborators, right? So included in that internal policy, there should be selection criteria that should include the quality of care, expected quality of care delivered by the potential team collaborator. They should not be based, obviously, we're not going to choose our collaborator on highest referral volume or business generated between the two. We're looking for those quality collaborators that can help advance our model design in our particular hospital. So in addition to quality of care, it's very important to consider, how they're going to contribute to your overall performance as a team participant. And once a team participant enters into a sharing arrangement, there's got to be oversight, right? This most likely, and CMS is going to want to know who's overseeing this. So most likely we'll land with quality and compliance to oversee that sharing arrangement and making sure not only is the participant hospital, but the collaborators are following that arrangement. Okay. Also, one final thing too with the collaborators, it's not punitive if they don't want to voluntarily participate, right? So prospective collaborators should voluntarily want to come on board. They're not penalized for not participating. If they're a collaborator for a certain part of the services they provide and not the other, again, there should be no penalty or any kind of feeling that they're being penalized if they're not participating as a collaborator, right? Because that beneficiary still has choice of care and quality of care, which is the most important. That is a lot of information in a very short period of time, but worth talking through. I don't want any of this to be a blind spot to anyone who starts implementing the model, because these are things that could easily be overlooked and are extremely important in requirements of the model. So I'm going to stop, see if there are any questions, and then pass it off to Ahmed to close us out.
Let's give it a minute to see if any questions pop up. All right. Well, as we wait, we'll just do a quick look back on, again, if you missed our last two series, we did cover a lot of great things that we've been able to build on top of this time. And so last time we had discussed the high level, the what, when, and why of TEAM, session 1. And our second session took a deeper dive into which MSDRG codes and HCPCS codes, as well as the CQS measures and how they will affect the reimbursements. Again, this is a long process and a new model. Our team is happy to assist. If you want a financial impact analysis, please find some time with one of our experts. You can follow us on a whole bunch of different social media platforms, or reach out to us directly, and our team will be happy to sit down with you and your facility to help prepare for this compliance module. We do have upcoming webinars that we will be doing, including some with executives of different health systems that are on the team mandated list as well, and covering different areas, including informatics, executive leadership, as well as patient safety and management. So keep an eye out and join us next time. Thank you all so much. See you next week.